Still confusing myasthenia gravis, Lambert-Eaton syndrome, end-plate potential, and neuromuscular blockers just before your MBBS exam? Don't worry. In the next few minutes, we'll divide the entire neuromuscular junction chapter exactly the way you need it in the university exam. Stay till the end because I will show you a 30-second master flow chart and one side final screenshot that can help you revise this chapter just before entering the examination hall. Welcome to the Rapid Revision series. Before diving into details, let's understand the roadmap. Everything in this chapter revolves around one simple story: how a nerve communicate with a muscle. We'll revise four major areas: structure of a neuromuscular junction, normal physiology, clinical disorders, and pharmacology. Our goal is simple: finish the entire chapter in a few minutes while remembering the highest yield exam points. Quick question: which disease affect the postsynaptic receptor? Keep the answer in your mind. We'll reach it in few slides. Let's begin with the anatomy. Imagine the neuromuscular junction as a bridge connecting a motor neuron to a skeletal muscle. Now notice three important parts. First, presynaptic terminal, where acetylcholine is synthesized and stored. Second, the synaptic cleft, where acetylcholine is released and also hydrolyzed by acetylcholinesterase enzyme. And third, the postsynaptic membrane, containing numerous nicotinic acetylcholine receptors. Remember this sequence because almost every disease and drug act at one of these three locations. In the university exam, always draw this label diagram after writing the definition. It immediately improves your presentation. Now let's revise the entire transmission in 8 simple steps. First, the nerve action potential arrives at a terminal button. Then voltage getting calcium channels open and calcium enters from extracellular fluid. This triggers exocytosis of acetylcholine vesicles into the synaptic cleft, and this acetylcholine diffuses and binds with the nicotinic receptors on junctional folds. This leads to the opening of acetylcholine-gated sodium channels and massive influx of sodium that lead to the development of end-plate potential. When this end-plate potential reaches a threshold that is minus 60 millivolts, it triggered muscle action potential and the contraction begins. Immediately after that, acetylcholine rapidly destroyed by acetylcholinesterase. If you can remember this sequence, you have mastered the physiology of neuromuscular junction. Now pause this video and try to recall the sequence without looking. Can you name all 8 steps? This slide connects normal physiology with the pathology. Let's revise it row by row. Voltage-gated calcium channels. It triggers the acetylcholine release. In Lambert-Eaton syndrome, the antibodies destroy these presynaptic channels. The acetylcholine vesicles. It releases the acetylcholine into the cleft by exocytosis. Here the botulinum toxin, it blocks the acetylcholine release from terminal. Then the nicotinic receptors. These nicotinic receptors where the acetylcholine binds and opens the sodium gates. The myasthenia gravis antibodies destroy these receptors, whereas curare blocks these receptors. And finally, the acetylcholinesterase. It clears the acetylcholine in 1 millisecond, which prevents the spasm. Drugs like neostigmine and DFP, it inactivates this acetylcholinesterase and prolong acetylcholine action. Think of this table as a master key to the entire chapter. This comparison is one of the most frequently asked university questions. In myasthenia gravis, the antibodies attack the postsynaptic nicotinic receptors, reducing the end-plate potential, causing fatigable muscle weakness. In Lambert-Eaton syndrome, the antibodies attack the presynaptic calcium channels, reducing the acetylcholine release, and again causing the muscle weakness. Here is the easiest way to remember it. Myasthenia gravis, muscle receptor problem. Lambert-Eaton, calcium gate problem. Never confuses these two. I will ask you one Viva question. Which disease improves temporarily with repeated muscle activity? If you answered Lambert-Eaton syndrome, you are absolutely right. Now let's revise the important drugs. Neuromuscular blockers. These block neuromuscular junction by 3 ways. First, by the receptor blockers. Here the drugs like curare and bungarotoxin, it binds to the acetylcholine receptors and prevent the end-plate potential development. Second are the depolarizing blockers. Drugs like succinylcholine and carbamazepine, they act like an acetylcholine, but they are not destroyed by acetylcholinesterase, so they keep the muscle in prolonged depolarized state. And third are the release blockers. Drugs like botulinum toxin, it prevents the acetylcholine release from terminal buttons. Now, the neuromuscular stimulators. These neuromuscular stimulators, they causes continuous stimulation of the neuromuscular junction and causes muscle spasm. They act by 2 ways. First, acting like an acetylcholine. Here methacholine and carbachol, they produce the end-plate potential but they resist acetylcholinesterase destruction, causing continuous spasm. And drugs like anticholinesterase, like neostigmine and physostigmine and DFP, it inactivates the acetylcholinesterase and causes prolonged action. So remember, you block the receptors, causes paralysis. If you block the enzymes, causes more acetylcholine release. This slide is exam gold. Let's quickly revise the favorite Viva questions, starting with the end plate potential. It is a local non-propagative positive potential and it triggers muscle action potential when it reaches a threshold of minus 60 millivolts. Next is miniature end plate potential. It is a random and resting release of acetylcholine. It causes magnitude about 0.5 millivolts, but here no action potential is generated. Then giant end plate potential. It causes due to more acetylcholine release. It rises to about 12 millivolts, but still incomplete to generate an action potential. The acetylcholine synthesis. Acetylcholine are synthesized in terminal mitochondria with the help of choline and acetyl coenzyme. The enzyme involved is choline acetylase. And lastly, the synaptic vesicles. One synaptic vesicle contains approximately 10,000 acetylcholine molecules. These facts are commonly asked during practical examinations. Without looking at the slides, answer this. What enzyme destroys acetylcholine in the synaptic cleft? This is your rapid division flowchart. Let's follow the journey. Here, the nerve impulse arrives and it causes calcium to enter the presynaptic membrane. So the acetylcholine is released by exocytosis and this acetylcholine binds with the receptor and causes opening of the sodium channels and end plate potential is developed. When it reaches the minus 60 millivolts, that is a threshold, muscle action potential is generated. And after that, acetylcholinesterase clear this acetylcholine. Now let's see the applied aspect at each level. Calcium entry. Here the calcium channels, they are destroyed by the antibodies in Lambert-Eaton syndrome. Now acetylcholine release, they are blocked by the botulinum. The receptors, these are blocked by the curare, but the same receptors are destroyed by antibodies in Myasthenia Gravis. And lastly, this acetylcholinesterase, this is blocked by neostigmine and DFP and it is bypassed by the succinylcholine. That's why this single diagram can help you revise the entire chapter in just 30 seconds. Time for the quick self-test. Pause the video and answer these questions before I reveal the answers. Question 1. What destroyed the voltage-gated calcium channels in the presynaptic membrane? And answer is Lambert-Eaton syndrome. Second question. End plate potential must reach what critical threshold to trigger a muscle action potential? The answer is minus 60 millivolts. And third question. Which depolarizing blockers act like acetylcholine but is not destroyed by cholinesterase? Answer is succinylcholine and carbamylcholine. Tell me honestly, how many of you answered correctly? Let me know in the comments. This is the page you should take a screenshot before leaving the video. It contains the entire chapter on a single sheet, starting with the anatomy and flow. This transmission starts from the nerve, enters the cleft and then passes to the muscle. The potential important here are miniature end plate potential of 0.5 millivolts when it becomes giant end plate potential of 12 millivolts and then ultimately end plate potential. But when it reaches threshold potential of minus 60 millivolts, it produces an action potential. Then the pathology and pharmacology one-liners. First about the myasthenia. Here the bad receptors. Lambert-Eaton syndrome, bad calcium gates. Curare, it blocks the receptors. Botulinum, it blocks the acetylcholine release. Neostigmine and DFP, it blocks the acetylcholinesterase. And lastly, the succinylcholine, it causes prolonged depolarization. Spend just 1 minute revising this page before your university exam and you will recall the complete topic with confidence. Congratulations, you have just revised the complete topic of neuromuscular junction in about 5 minutes. If you are preparing for the university exam, don't stop here. Watch the main video to learn how to write a perfect 10 marks answer with examiner-friendly headings and diagrams, and then watch the memory video to master the Lambert-Eaton syndrome and Myasthenia Gravis using a simple flowchart and memory tricks. If this revision helped you, like, subscribe to PhysioWithNeo and share this video with your classmates. I will see you in the next rapid revision session. Happy studying.